record. Okay. So when we left off, I was telling you about the embryonic development of the pituitary and how wonderful and strange it is. So that involved the pharynx reaching up and the brain reaching down. And by the end of development, we have this odd sort of bimodal appearing gland, and that is going to account for the histological difference between the two sides, which is handy for you because one of your major tasks is recognizing the difference between the two visually. And fortunately, this is one of the few places in histology where that's actually not that hard. So one of the things that is hard is all of the different names of things. So there's the pituitary, which is the whole thing. That's also called the hypophysis. And then there's the anterior pituitary, which is also called the adenohypophysis. So the difficult thing perhaps is keeping track of all of the different and yet synonymous names for all of this stuff. So that's kind of tricky. So we have this little drawing up here for context. This is the anterior pituitary. This is the posterior. You can always tell the difference because the anterior pituitary has this bulgy part down here, which is the pars distalis, which is Latin for distal region. So it's just at the end. And it has this area called the pars tuberalis, which wraps around the infundibulum. So that's how it kind of hangs on. There is a cellular difference between the regions as well. So the pars distalis is the bulbous end bit, and that is about 75% of the gland in total. And you can divide the two cell types into chromophils and chromophobes, excuse me. So chromophil means color lover and chromophobes means color fearer. So they're named according to how readily they like to take up the hematoxylin and eosin stains. So within the chromophils, they're either basophilic or acidophilic, which you guys are well acquainted with by now. And that's due to the chemical nature of whatever hormone it is that they are making and storing. And if you think back to the slide 29 that I showed you previously, the anterior pituitary is responsible for a lot of different hormones. So there's going to be a pretty significant amount of cell diversity in this anterior region. The pars intermedia is a thin zone of cells between the pars distalis and the pars nervosa. In this picture, it's here, and you can actually see these cells are a little bit darker than their neighbors. But there's a couple other ways to identify it, and I'll show you that. The primary one is, if you can find the pars nervosa and just go to the border, it's right there. The other is, see these little sort of open spaces here? These are called Rathke's cyst. They are a leftover of embryonic development, and they mark the pars intermedia pretty reliably. Finally, we've got the pars tuberalis, and that's that little clingy bit. It's not especially wonderfully represented here, but it is present. And it's funnel shaped because it's wrapped around the infundibulum. And most of the cells in the pars tuberalis are the gonadotrophs, meaning they are going to be making follicle stimulating hormone and luteinizing hormone. Now, towards the end of this class, we have the privilege of discussing the sex organs and reproductive histology and anatomy, as well as doing some cool sort of discussion of the embryonic and hormonal development of sex characteristics, including primary ones like gonads and secondary ones like breast tissue, skin changes, etc. And just how non-binary all of that is. I think, now, because we live in a slightly more advanced society than we used to, there are things to be grateful for about being alive right now, even though it doesn't always seem like it. One of the benefits that we do have now is that, it's finally being acknowledged that gender exists on a spectrum, and sexuality and sex parts do as well. And it's a awesome thing to be able to freely and openly talk about those things and how they're interrelated and that kind of thing. So we're going to talk about that a little bit here because the endocrine system absolutely plays into that, and also more when we get to the reproductive system. So stay tuned for that. The reason I mentioned it in the context of this is because follicle stimulating hormone and luteinizing hormone, which is made by the gonadotrophs, are responsible for acting on the testes and ovaries respectively to cause gametogenesis and cause sex steroid hormone secretion, and that contributes to things like maintenance of secondary sex characteristics. So it's germane to introduce here. Okay, and now we get to look at some pretty colors. So what you're seeing here are 3 different staining options for this tissue. In the leftmost image, you can see eosinophils are very bright magenta, and then the basophils are darker purple. This is a sinusoid, meaning a very disorderly looking blood vessel. And this is how all of these cells have close access to the blood to dump their product into the bloodstream. Here's another sinusoid. This is perhaps the fattest, biggest eosinophil I've ever seen. That's quite impressive. But regardless, their thing that they have in common is they readily take up the pink stain. There is a squirrel trying to steal seeds out of my bird feeder. I'll allow it. Not my squirrel, outside squirrel. So this picture, I don't like this stain as much, but it's worth putting here just to show you that there is indeed quite a bit of variation in how readily this tissue takes up stain. And as you guys know, because you're actively doing it, that's one of your major challenges for recognizing histology structures, is that you cannot reliably say that a given tissue will stain the same way every single time. I think you'd probably agree that when you're looking at various slides of things, that's one of the biggest challenges in histology. I also spent a little bit of time on Reddit today looking at student opinions of how difficult or easy learning histology is. I did it for my own reasons related to my other class, but suffice it to say, students have strong, mostly negative opinions about histology and its difficulty. And I get why. It's hard. Yeah, I would agree, especially since a lot of, so the comment, by the way, for the recording is that's probably the only plus in doing histology online is that you get to have a little bit more consistency than you would in person. And that's absolutely true. I can tell you, if, for example, you took histology at PSU, for example, most departments that I've worked in are not very good at keeping fresh, up-to-date histology slides in stock. And one of the difficulties is that the slides tend to become oxidized and lose their stain intensity over time and just get crappier. And if the collection is not maintained very well by whoever's in charge of it, then students suffer. So that is not your fault. That is their fault. But yeah, and also the ability to look at 2 slides at once is excellent. And I can't recommend that enough on a histology guide or whatever you're looking at, having 2 tabs so you can do side by side. Invaluable, just so useful. Okay, so finally, I think this one's the prettiest. So we've got eosinophils taking up the orange aldehyde-based stain here, and then the basophils, confusingly, are staining pink, and there aren't very many of them. The benefit of this stain is that you can really, here's a basophil, the acini or acinar nature and the separation with connective tissue is very apparent, which is nice. And you can resolve the variations in chromatin storage across the cells, which is neat. So here's a little list of which cells are basophilic and which cells are acidophilic. So we've got corticotropes, which make adrenocorticotropic hormone, gonadotropes, which make, as I mentioned, follicle stimulating and luteinizing hormone, and thyrotropes. These are all basophilic. And then somatotropes and lactotropes, so growth hormone and prolactin respectively, are acidophilic. And as you can see here, there's an abundance of acidophils here and here. Here there's less, so it also varies according to where in the adenohypophysis you are. So let's talk about adenomas. Pituitary tumors are not that uncommon, and they're benign in that they don't metastasize, but I would caution you that benign does not necessarily mean non-harmful or not efficacious. So one thing that happens with benign pituitary adenomas is that it can cause gigantism if it occurs in children before the closing of the epiphyseal plates. So there's too many cells that secrete growth hormone, and so the kids get really big really quickly. The name for that phenomenon in adults is acromegaly. So pituitary gigantism and acromegaly are two different things technically, because it depends on what developmental stage the individual was at when they experienced the adenoma. But let's look at the phenotypic outcome of that just real quick. Yep, Andre the Giant and others. Andre the Giant, may he rest in peace. Yes, he's no longer alive, unfortunately. But as you can see from these fun wrestling photos, he was a really, really large man. Here's a relative size. So it's kind of clear here, but it's really clear here and here. And then here's some historical imaging of acromegaly. As you can see, I like this sequence of events especially much because this person is obviously already a mature adult, and yet you can see continuing changes specifically to craniofacial morphology over time. And hand morphology as well. So acromegaly has neurological consequences as well, because your bones have, as you know, little foramina in them. And the foramina are little holes that blood vessels and nerves pass through. So if there is inappropriate bone growth and remodeling, those holes can become constricted and push on nerves. So it's uncomfortable. And you face circulatory changes as well. People with gigantism and acromegaly are also at increased risk for blood clots and thromboembolisms. So there's some medical risk there as well. Oh yeah, I forgot about that. I love Princess Bride as well. And yes, he was great in that. All right, neurohypophysis. So this obviously looks super different. So let's just go back for 1 second. So here we have a tissue that's very cellular and very dense and full of sinusoids. And here we have a tissue that is diffuse and it's got a lot of negative space. So even if you can't compare and contrast the two directly side by side, just the tissue difference alone is pretty striking, even if you have a hard time with histology. So one thing to point out, and this is something that I emphasized last class because I was trying to stress the difference between the communication between the hypothalamus and the pituitary. But the neurohypophysis does not make the hormones that it releases. Those hormones, again, antidiuretic hormone and oxytocin, those are synthesized in the hypothalamus. They are only released from here. So what you're seeing are the ends of axons that are neurosecretory in nature. And these are characterized by these neurosecretory herring bodies. Here's one. And those are the release sites. And then we've got pituocytes, which are mostly what you see. And pituocytes are glial cells. They're kind of like astrocytes. They're there to support the action of the axon terminals. And then we've got capillaries, of course, for distribution of the hormone. So posterior pituitary function is critical. One of the functional differences that the structural difference imposes, so that it's structurally dissimilar from the adenohypophysis, one of the functional consequences for that is that you can send an action potential and release antidiuretic hormone and or oxytocin very rapidly. So it's possible to see fairly large swings in plasma ADH or oxytocin in response to various stimuli, changes that would take longer for a tropic hormone from the adenohypophysis to do. So that's on purpose because oxytocin and vasopressin are typically needed for a short amount of time and they need to be relatively fast acting. So that's why. But they're also very, very important. So if there is a mutation in the gene for vasopressin neurophysin, because remember, these are peptide hormones, so there's a gene for them. They are being expressed like any other protein. So that's one possibility, is you're not making quality vasopressin, or if you have a pituitary tumor that is squishing your neurohypophysis and not permitting it to release things, or head trauma, you can get hyposecretion of vasopressin, and that produces something called diabetes insipidus, which means that you cannot concentrate your urine. And that leads to polyuria, so frequent urination. So you're losing large volumes of water in your urine and increased thirst. So interestingly, we think of diabetes as being this one specific disease that presents in one way, but it's possible to get knocked in the head and have diabetes insipidus result from the subsequent inflammation. So if you're at, whenever it is that we can go back to doing things like pub trivia, I have heard this question at pub trivia before, and so that can be your like winning move. It is possible to get bonked in the head and get diabetes from it. That's true. Just not the kind that you're used to. Okay, the adrenal glands. They are on top of the kidney, like a little hat. You have one per kidney. Because it comes up, I do want to note, a lot of people ask, when you donate a kidney, does the adrenal gland come with it? And the answer is not usually. And as you can see, one of the reasons for the ability to leave it in its place so that you don't end up with adrenal insufficiency is it has its own blood supply that comes off of the aorta independently of the renal artery. So you can just take the kidney and you can leave the adrenal gland in place. So these produce steroid hormones, but the inner medulla produces catecholamines, which is the group word meaning epinephrine and norepinephrine. So they look like this. They are a yellowish glandular epithelium, very classical in appearance. They are roughly triangular. The capsule of each oh yeah, I've seen that in cadavers before. The comment is when you get a transplant, the old kidney just gets left in there. In some cases it does, yeah. I've actually seen that in cadavers before, and the old kidney is like full of, yes, but only two functional ones in a lot of cases. The old kidney is like cratered and atrophic. It's interesting. So adrenal glands are very, very important because they allow you to deal with stress. And I am talking about physiological stress here. Sometimes mental stress and physiological stress go hand in hand, but the relationship between the two is not necessarily or directly causal. So I just want to be very clear about what I mean when I'm talking about this and the hormones of it. I mean physiological stress. So the repeated series of ordered and very well understood changes to primarily body fuel use that are a response to a stressor. So stressors include lack of food availability, illness, injury. Exercise is technically a physiological stressor, so all kinds of things. A stressor is really anything that challenges normal homeostasis. So the capsule is the connective tissue protecting zone, and then right below that we have the zona glomerulosa, and that is comprised of these little sort of clump or ball-like acini, and that's where the term glomerulosa comes from, because it looks glomerular in nature. And then below that, we have the much longer zona fasciculata. So fascicles are stacks of cells, and as you can see, the zona fasciculata is arranged into these fascicles or columns. And then closest to the adrenal medulla, you have the zona reticularis. This one's interesting because this one produces androgen primarily, so it's a secondary source of sex steroid hormones in addition to the gonads. I want to address the question in the chat, which is, has anybody else gotten jump scared so badly by something that you felt your body tingle after that? I certainly have, and I think it's a pretty universal human experience. The reason for that is that the epinephrine and norepinephrine release, along with nitric oxide, which is a gasotransmitter released by some sympathetic nervous systems, is rapidly released onto your blood vessels, especially your capillaries, and you can actually feel the capillary changes as blood is suddenly in places in your body where it wasn't before. And piloerector muscles also do go up and give you goose flesh, but the primary tingly feeling is the arrival of blood where it was not mere seconds before. So if the stressor persists after what we just described, which is the acute phase, then that is when the adrenal gland gets involved. So we'll work through the adrenal gland bit by bit. Okay, so let's look over here for some context. We've got our top layer, which is zona glomerulosa. We're ignoring the capsule because it doesn't contribute anything endocrinologically, right? It's just connective tissue. So the zona glomerulosa is here, and it's here and here. So we're showing you two different views of it once again, just because, as you guys know, not everything stains equally. Oop, geez. There we go. So it's a little bit more apparent over here on the right, but you can see that the zona glomerulosa cells are arranged into these little globs. Not quite as apparent over here because this stain isn't quite as intense, but you get the idea. You can see that the cellularity and cytoarchitecture of this bit is different from what's down here. So the zona glomerulosa produces a group of corticoids called mineralocorticoids, but the main contribution it makes is aldosterone. And that's part of the renin-angiotensin-aldosterone system that is there to help you conserve water and increase your blood volume. The zona fasciculata, and this should say fasciculata, but fasciculate is what the autocorrect likes to change it to because this is an English word. Fasciculata reflects the fascicle arrangement of cells. And here you can see the zona fasciculata, and in this one, the sinusoids present in the zona fasciculata are a little bit more apparent. The reason that they look spongy is because they're producing large amounts of steroid hormone glucocorticoid, which isn't miscible with water. So it causes a foamy appearance of the cytoplasm, if you look closely. And then the zona reticularis is often very much more darkly stained. So you can see it down here. And this secretes sex steroids, primarily androgens, so androstenedione, et cetera. But those are easily converted to other sex steroid hormones by a variety of enzymes. So we'll talk about congenital adrenal hyperplasia a little bit, but that basically is a situation where there's a overabundance of reticular cells, which produce too much androgen, and it causes steroidal havoc, resulting in all kinds of phenotypic changes. So if you're going to be a doctor and you do PEDS rotation, typically congenital adrenal hyperplasia is acknowledged and addressed in the pediatric unit. And so that might be something that you come across, or if you do an endocrinology rotation as well. So trying to give you heads up for things you might see when you are doing rotations in med school and residency. So let's look at the adrenal medulla. The chromaffin cells, this is a similar word to chromophil. So chromaffin is, they have an affinity for stain. So they're large, they're pale staining, but they take up stain uniformly. And they're arranged in sort of cords, not unlike the cords in the lymph nodes or the spleen, you might remember. And then between them, there's big capillaries. So you can see cords, capillary, etc. So between the two, norepinephrine secreting cells tend to be more electron dense, but it's hard to see that with H&E. You can see it much better with TEM, which is what this is, as you now know. So you can see the very electron dense norepinephrine cells. Here we have a capillary, and then over here we have the epinephrine secreting cells. There's a little bit less stark division here, but you can see this electron dense darker cell is more likely to be a norepinephrine cell, whereas these lighter guys are going to be epinephrine. So medical application, television show edition. I don't know if you guys watch or have watched the television show House. Have you? A fun game to play when you're watching House is try to count how many repetitions there are during the parts of the show where they're in the diagnosis room and the participants on the team are throwing ideas out there. Someone almost always says pheochromocytoma. Almost always. So watch for it. Other common ones, yeah, it's never lupus. It's all like pheochromocytoma is a common one. Hashimoto's thyroiditis is another common one. But it seems like whoever is the writing consultant on the show gave the writers like a list of 20 illnesses, and they kind of just cycle between them. And for whatever reason, pheochromocytoma comes up a lot. Now, it's an interesting pathology because the overabundance of these chromaffin cells coincides with, well, I bet House makes an actual doctor really mad. I would be mad too. There's so much in there that is, not HIPAA friendly, or it doesn't make any sense, or is just blown out of proportion. So interestingly, pheochromocytomas don't consistently cause high levels of catecholamines. They do it sporadically. And one of the reasons for that is that these cells are essentially modified neurons. So they have the same markers, the cell surface markers, as neurons do, but they are anaxonic. They release catecholamines in response to direct sympathetic innervation. So what you sometimes see with pheochromocytoma patients is that any emotional agitation or being frightened can set off their pheochromocytoma symptoms because the adrenal medulla is receiving electrical impulses that are telling these cells to release whatever catecholamines they have. And because they are overabundant, they have a lot to work with. Okay, pancreatic islets. Also, let me tell you a short story about pronunciation and being a student and embarrassment. There are some words where if you never hear the word said, you wouldn't know how it was pronounced, and islets is one of those. One thing that happens a lot more in my A&P classes, but some here as well, is that if a student chooses to talk and ask a question, they'll often apologize for not pronouncing something right. And it's my firm position that you should never apologize because you're learning. So let me tell you the story about how when I was in early grad school, I had to do the endocrine presentation for the TAs in the A&P TA group. And I, in front of everyone, pronounced this word islet because I had never heard it spoken before. And then everybody made fun of me and it was super duper embarrassing. So please understand from me to you that if you ever pronounce something wrong, I'm never going to give you crap about it because that's not what you deserve. It sucked for me and I don't want to repeat that experience and send the trauma down the academic generational line. So the word duodenum is also a difficult one. So islets is how you pronounce this, not islet. And islets are interesting because they're a little sphere of endocrine cells studded among exocrine cells, which is fascinating. So the pancreas is what's called a heterocrine gland because the majority of the tissue is just arranged into exocrine acini, which produce trypsin, chymotrypsin, other pancreatic juices, as we discussed previously. But then there's these little clumps of cells here and there that secrete hormone. So within these, there's alpha cells, beta cells, delta cells, and pancreatic polypeptide cells. Now, can you distinguish between and among these in a hematoxylin eosin stain? No, absolutely not. And I don't expect you to, but that's what's in there. So alpha cells make glucagon. Easy way to remember this is glucagon is secreted when glucose is gone. So low blood sugar situations. So this causes the breakdown of glycogen. The name, here's another fun word, I'll type it for you. The way to say breakdown of glycogen is this. Glycogenolysis. It also causes the breakdown of triglycerides and conversion of fatty acids into glucose to increase your blood glucose. So you can actually magically transmogrify fat into glucose in an emergency, which is a nifty little trick your liver can do. Insulin is probably everybody's most familiar hormone here. And this is secreted by beta cells. These cause uptake of glucose, so they cause blood glucose to drop. This is reason numero uno why it's very important in a medical setting to be careful with insulin administration because it's a very, very effective way to drop blood glucose, and it's possible to put someone into a coma by misusing insulin. And people have tried to kill each other by doing that for many, many years. If you just throw insulin murder into Google, you'll find all kinds of news stories. Occasionally, you'll see it on like 2020 or Investigation Discovery. There's a snail that does it to fish. If you can find a link for that, please send it to me. I'm betting it's a cone snail. It's fascinating. So somatostatin is secreted by these little delta cells. Haha, I'm thinking about snails. And this is an antagonist of growth hormone. So growth hormone is regulated a bunch of ways. One of them is by feedback. The other is by an interplay between somatostatin and it. So somato means body. Statin means stasis. It also inhibits TSH, thyroid stimulating hormone, and that's for a similar reason to growth hormone. Usually, if you see an increase in growth hormone, you also see an increase in TSH. And that is because if you're going to be doing a lot of growing, you need to be increasing your metabolism and therefore stimulating your thyroid gland. So that's the reason for it. So it also interestingly suppresses hydrochloric acid secretion by parietal cells, which, as you can imagine, probably downpowers digestion. So there's another thing. Pancreatic polypeptide cells, these also act on the stomach, but in chief cells, and they inhibit bile secretion, et cetera. And that makes sense, right? Because if you look at the placement of the pancreas here, we've got the head of the pancreas, the tail of the pancreas, here's the duodenum, and then above in this cutoff area would be the stomach. So essentially, there's this, during stomach emptying, there's a complex chemical conversation that is constantly happening between your pancreas, your duodenum, and your stomach. And that conversation involves paracrine signaling, endocrine signaling, and neurofeedback as well. So digestion is not as simple as food moving through a tube, which I know you guys are aware of, but I cannot stress enough what an intricate dance it is. And this is just another layer of that. Okay, so I mentioned you can't see the difference between alpha and beta cells, et cetera, in hematoxylin and eosin. And as you can see from the left, you sure can't, but you absolutely can if you use a special modified aldehyde fusion stain, which produces this picture, which has a very 70s color palette, and I find very soothing to look at. So the alpha cells tend to be around the edge, and they are a deep brownish purple color, which is very nice to look at. And the beta cells are brownish orange, which is so that you can see that better here, but you would never be able to see it over here. You can also just do immunohistochemistry that creates antibodies against the islet polypeptides, which allows definitive identification of every cell type, not just alpha and beta cells. But of course, you would have to be, doing research on that or some such. So coming across those slides is challenging. Okay, so let's talk about diabetes. All kinds of problems come about with diabetes. I just gave my A&P students a case study about metabolic and respiratory acidosis and ketoacidosis and diabetes problems. And so we could talk about it a little bit here. So diabetes mellitus is the loss of the insulin effect. So basically, you cannot move glucose out of your blood, which means that the glucose stays in your blood, and that gives you what's called hyperglycemia. So we have two types of these, and I want to say that this is distinct from diabetes insipidus. Remember, diabetes insipidus is the ADH one. Diabetes mellitus is sugar related. So type 1 diabetes, and this is the insulin dependent type, is caused by loss of beta cells. This is usually because cytotoxic T cells attack and kill the beta cells because something about them resembles something that the immune system is angry at. So autoimmune diseases include type 1 diabetes. Type 2 diabetes, this is non-insulin dependent diabetes. These are beta cells that are still there, but they don't produce enough insulin for whatever reason. And in response to the consistent hyperglycemia, the target cells become what's called insulin resistant. So they don't respond to whatever insulin there is. And this seems to be a spectrum disorder because there's a bunch of factors that predispose one to it, but there is no one sort of universal cause, nor is there a universal combo that guarantees you do or do not end up with it. So it's one of those things where it's not completely understood because it seems to be an interplay of a lot of things going on at once. Some of them lifestyle choices, some of them genetic, some of them a question mark. Who knows? So these are sort of some nice little summary cycles of this. You get ketoacidosis here due to glycogen and protein breakdown. So your body is like, well, can't use glucose for some reason, so I guess I'll use other stuff. The muscle is unable to use the glucose due to the low insulin. Then you get increased glucose in the blood, decreased insulin, and you have this problem with acidic hyperglycemic blood. And type 2 diabetes is we don't have enough insulin. In the end, you do initially, but the receptors for the insulin are downregulated in target tissues, so they no longer respond. Okay, thyroid gland. This is a nice cadaver neck dissection of the thyroid gland. Is it this color? No, it's been falsely colored here to show you. Interestingly, in most people, the thyroid gland has two wings and an isthmus. In this person, they have a central wing as well. There is a fair amount of variation in the morphology of the thyroid gland. So it's mostly vaguely butterfly shaped, but not in everybody. So to give you some context here, these are the submandibular salivary glands. These are going to be the anterior belly of a jaw floor muscle. Here we have throat muscles. Here we have phrenic nerve and some carotid and jugular action. And then this is part of the omohyoid. This is the digastric. And then we have clavicles and some fat. So the thyroid gland is the largest endocrine gland in adults. In adults. Remember, children have weird glands, including a weird thymus. They have a weird, huge thymus. But in adults, the largest one is the thyroid gland. It's even bigger than the adrenal glands. And it's made up of little balls of cells that secrete a colloid. So a colloid is just a suspension of proteins in fluid. So milk is a colloid, for example. In the case of the thyroid gland, hold on, I'm going to sneeze. Okay, sneeze done. In the thyroid gland, the colloid is T3 and T4 thyroid hormones suspended in a plasma-like fluid. Oh, interesting. Someone in the chat, someone is saying, someone I play video games with no longer has a thyroid. We will actually discuss a little bit about what happens when you have your thyroid removed for various reasons. So it's combined, it's a combination of follicular cells, which are simple cuboidal, and then parafollicular cells, which create something else. So here's what a follicle looks like when you slice it. We've got a cuboidal epithelium that's shaped kind of like a kiddie pool. And then in the center, there's this uniform pink stuff. That's the colloid. So thyroxine and triiodothyronine are two different hormones, but they are similar. And they're named that based on the number of iodine atoms. So T3 is more active than T4. T4 by itself does have some thyroid action, but T3 is the real potent stuff. So most of our T4 is converted to T3 to increase its efficacy. So this is going to increase metabolic rate. So increase the rate at which you're oxidizing oxygen to make ATP. It has a calorogenic effect, which means heat production. It makes you hungry. There's growth hormone secretion. Remember, I said that growth hormone and thyroid hormone kind of work hand in hand. And it does increase central nervous tone to contribute to alertness and quicker reflexes, but nothing superhuman, right? You wouldn't turn into a Superman if you had a big thyroid, so that's not going to happen. Sorry, guys. Parafollicular cells, also called C cells, which are these little guys right here, these secrete calcitonin. And calcitonin tones down blood calcium. So it stimulates osteoblasts to move calcium out of the blood and into the bone. So it's important to have adequate calcitonin. It seems to be more important in children who are still forming their bones rather than adults, but you still need it at least a little bit. Parathyroid hormone is a bigger player in adults. So let's talk about endemic goiter. Endemic goiter is an enlargement of the thyroid gland due to insufficient dietary iodine. So if you go to the grocery store and you look at the salt section, you'll have a choice between iodized salt and not iodized salt. So if you've ever wondered to yourself, like, why do they put iodine in salt? And why do I have a choice? Which one should I choose? Am I making the wrong choice? Now I have salt anxiety. The reason iodine is put into salt is because it readily crystallizes into it and because salt is delicious. And from a public health perspective, it's easy to encourage a population to consume a necessary micronutrient if you put it in something yummy. So that's why. So what happens if you don't have enough salt? This is a good opportunity to draw the hypothalamic pituitary thyroid axis and talk about what happens when you break a negative feedback loop. Oh yes, as is being acknowledged in the chat, iodide is also a great way to make sure that water is safe to drink, but it tastes super icky. But if you have the choice between drinking water or not, you have to drink water. So, but also, it helps you avoid things like giardia, which is very unpleasant. Okay, so let's draw a feedback loop. So I'm going to switch my screen share for a moment so I can draw for you. Screen number 1. Maybe. Yes. There. Okay. So let me move the chat and then I will. So hopefully you're seeing a white screen, which will shortly not be white. After I get done drawing this, I'll show you what giardia looks like histologically, since this is histology class. They're actually like weirdly cute microorganisms. Yeah, but giardia is all over the place and there's a season for it. So don't let your dog drink puddle water at the dog park because giardia season will cause your dog to get very severe diarrhea, which is fun for nobody. Okay, so let's draw ourselves a hypothalamus. And then I will draw the posterior pituitary for posterity's sake, but that's not what we're going to focus on because it really has nothing to do with thyroid gland. Okay, so there's the anterior pituitary. So the hypothalamus is going to release thyrotropin releasing hormone. And that acts on the adenohypophysis, causing the adenohypophysis to produce thyroid stimulating hormone. So thyroid stimulating hormone does exactly what it sounds like it does. It stimulates the thyroid. So let's draw ourselves a normal size thyroid first. So thyroid stimulating hormone is going to do this. And then with enough iodine, it will make thyroid hormone. So based on how this feedback loop works, T3 and T4 actually feed back negatively on the pituitary and also on the thyroid, or on the thyrotropin releasing hormones producing cells of the hypothalamus. So what this does is help keep the amount of circulating thyroid hormone reasonable. So you don't want too much, because then you'll have a hard time keeping on weight and other things. I'll show you what Graves' disease looks like. And you don't want too little, because then you have a hard time keeping weight off and you feel tired and sluggish all the time. So there's like a Goldilocks amount of thyroid hormone, and negative feedback is how that's accomplished. But what if there's not enough iodine? So you're like, nope, sorry, no iodine for you. Then T3 and T4 are insufficient to negatively feed back. There's just not enough in there. So in response to this disinhibition, you see a big increase in TRH, because the hypothalamus says, I'm not receiving any input from the thyroid gland, so we must need to secrete more thyroid hormone because I have no negative feedback. So I guess I'm just going to make a bunch of TRH. And that stimulates overproduction of TSH, which stimulates the thyroid. So what happens is overstimulated tissues hypertrophy. So what the thyroid is saying essentially is, okay, I'm trying to make thyroid hormone. I'm doing my best. And in an effort to do my best, I'm going to get bigger because I'm being stimulated so hard to make this thyroid hormone, except I don't have the necessary building blocks to make it. So I'm getting bigger for no reason. So that's how iodine deficiency gives you an endemic goiter. It's basically your hypothalamus and your pituitary yelling and screaming at the thyroid gland, hey, idiot, make thyroid hormone. And the thyroid is like, doing my best here, don't have the parts. Sorry, can't do it. So I'll show you some pictures of what endemic goiter looks like and how to avoid it. And then I'll show you some other thyroid pathologies just real quick, because it's always fun to see why what you're learning matters to you. So I'll pull those up to the top screen, but let me just make everything normal again. So endemic goiter first. And we're going to do some more celebrity endocrinology. So this is not fat. This is hypertrophic thyroid. So as you can see, that's a quite severe case of it, but you get the idea. Here we have some individuals with it. The reason this is the example picture and it's on ResearchGate is because in places where the primary source of calories is cereal grains and certain kinds of vegetables are not as available, endemic goiter is a community level problem that's based on nutrition. You can also just give yourself an endemic goiter by having weird food preferences. So if you're like, I only eat starch and nothing else, then you can give yourself a goiter just by that. So how do you treat this? Well, you supplement with iodine and the problem goes away. Okay, so we talked about Andre the Giant and his famous role in The Princess Bride. Another very famous movie with a very famous endocrinologically challenged person is Young Frankenstein. If you've seen it, Igor in Young Frankenstein is played by Marty Feldman. And the reason he got the role is because he has a condition called exophthalmia, which is this. So exophthalmia is one of the spectrum of symptoms that is caused by hyperthyroidism, specifically a kind of hyperthyroidism known as Graves' disease. So interestingly, it seems like inflammation due to hypersecretion of thyroid hormone inflames the tissues behind the eye and pushes the eyeballs forward, creating this very, very sort of iconic phenotype. But exactly why it affects the eyes in this way is not very well understood. Fortunately for Marty Feldman, it got him lots of work as a character actor just for being kind of weird looking. But yeah, if you need an excuse to go watch Young Frankenstein again, I strongly recommend it. Or he's also involved in Monty Python, so all kinds of fun things to go do some school-based movie watching. So go watch Princess Bride, go watch Young Frankenstein, and if anybody asks, you can just say that I told you to. I said you have to. Yes, and I agree that it's interesting that for whatever reason, some mammals and vertebrates can produce their own micronutrients like iodine or vitamin C, and others can't. I suspect iodine is specifically because it's a metal that exists in the environment. So this is Graves' disease, and it is also an autoimmune disorder. So weight loss, nervousness, sweating, heat intolerance, and other features are present in addition to the exophthalmia that I showed you in Mr. Feldman there. And then hypothyroidism can be caused by thyroiditis. It can also be autoimmune. So Hashimoto's thyroiditis is a type of hypothyroidism that is also autoimmune, but opposite to Graves' disease. Or you can have a lazy pituitary gland that is not secreting enough TSH. So in order to figure out which it is, you would, of course, have to have a blood test. Okay. So I want to point something out, and that is thyroglobulin is not synonymous with T3 and T4. Thyroglobulin is a stabilizing molecule because thyroid hormone is not actually water soluble. So in order to be suspended in the colloid and also to be capable of being transported in the blood, it has to stick to something, and the thing that it sticks to is thyroglobulin. So follicular cells produce mostly T4, which is converted into T3, but it's not converted there. It's converted in the peripheral organs. And that's actually very clever because think about how potent thyroid hormone is and what it does. One thing that you don't want is for thyroid hormone to be affecting cells and tissues on the way to where it's supposed to act. So a good way to prevent that is to send it in a less active form to the place where it's supposed to go, and then have it get activated once it gets there. And so that's what we're seeing here. Interesting crossover function of TRH, thyrotropin releasing hormone. It does, of course, cause the release of thyroid stimulating hormone. It also mediates the release of prolactin, which is going to promote the ductal and glandular development of the breast to prepare for lactation during pregnancy. So we have to take a break for a couple minutes. So here's what I would like you to think about during the break. Why would it make sense for a releasing hormone that mediates thyroid activity to also regulate breast tissue development? So have a ponder about that, and then I'll see you back here in about 3 minutes. So on the back of the parathyroid glands, or the thyroid, excuse me, we have the parathyroid glands. So it's this weird thing where it's kind of like pancreatic islets in that there's these little 4 studs of alternate tissue in this sea of thyroid tissue. And one of the reasons that this makes your job as histologist easier is because this picture isn't really doing it justice. But in general, when you have a slide that has a parathyroid gland on it, you can also see thyroid tissue on the slide, which means that it has to be the parathyroid gland, right? So that makes things a little bit less ambiguous for you. So every book I've ever taught from illustrates them as being 4 evenly spaced parallel dots on the back of the thyroid. This is not actually true. There's variation and phenotypic plasticity in the placement of the parathyroid glands. So they can be super high up, they can be really low down. Sometimes somebody has one big one on one side, for example. So as long as you have sufficient parathyroid cells, you are fine. Their exact physical configuration on the thyroid gland does not matter. So parathyroid hormone is an antagonist of calcitonin. So where calcitonin tones down blood calcium, parathyroid hormone increases blood calcium. And it does this through a variety of methods. One is preventing the urinary excretion. The other is promote synthesis of the active form of vitamin D to facilitate calcium absorption. And the final one is they act on osteoclasts to cause harvesting of calcium from the bone and dumping it into the bloodstream. So before the break, I mentioned that calcitonin seems to have less significance in adults than children, and that parathyroid hormone is kind of the big player in adult calcium homeostasis. And that's true. So earlier, someone in the chat mentioned that their friend does not have a thyroid gland anymore. That can happen for a variety of reasons. Usually it's that a tumor is found and the entire gland is resected. Often the parathyroid glands come along for the ride. But if that happens, you need to have immediate replacement with parathyroid hormone medically, or you will suffer from hypocalcemia that is life-threatening, and that causes nervous system depression, heart arrhythmias, all kinds of problems because of how pivotal calcium's role is in things like muscle contraction and neurotransmitter exocytosis. So you really, really need it. So histology-wise, it's a multilobular tissue. So you see lobules of parathyroid tissue separated by septa and then surrounded by thyroid tissue. And the principal cells, which confusingly are also sometimes called chief cells. There's a lot of chief cells. So we're going to call them principal cells just to avoid confusion with the chief cells of the gastric mucosa. But the principal cells are very, very densely packed such that what you see is mostly nucleus. And then older thyroid or parathyroid glands, so those of older individuals, have an increased number of oxyphil cells, which are these guys down here. They're larger and they're acidophilic, and they seem to have no function. They seem to be simply an atrophied principal cell that happens with age. So similar to involution of the thymus, we have changes to the parathyroid gland with age. Oxyphil cells, like I said, appear to be non-functional, but their exact nature is not very well understood. So I have this creeping suspicion that they actually do more than what we think that they do. And I'm just kind of hanging out waiting to see that pop up on AAAS or Science News or whatnot. So hypoparathyroidism, not to be confused with hypothyroidism, this is a diminished secretion of PTH, and it becomes a problem because you have hypermineralization of the bones, which can result in something called Paget's disease of bone, which is where your bones thicken out of control and begin to crush your nerves, etc. And they also cause issues with striated muscle because if you change muscle concentration, you change plasma calcium, and that causes issues with having enough calcium to produce contractions. Excessive PTH produced in hyperparathyroidism, it does the opposite. So basically it selectively mobilizes calcium at a higher than normal rate. And that's damaging because calcium doesn't have that good of solubility in plasma. And so it's easy to reach a critical mass where it begins to crystallize and seed crystals and deposits, which can end up being deposited in tissues where it shouldn't be, including arteries and the kidneys. So you do not want stalactites in your arteries, and you certainly don't want calculi, which I showed you last time. Okay, the pineal gland. I love the pineal gland. It's my fave. The pineal gland sits here. So this is the thalamus. Here's the corpus callosum. You can't really see them that well, but here's the superior and inferior colliculus back here. So it's just above those. And unlike the colliculi and other structures I've mentioned, it's not bilateral. So it's deep in the brain and there's only one of them. It's called the pineal gland because in early dissections, when it was discovered, it was thought to resemble a pine cone. So the people that discovered it were like, wow, that sure does look pine coney. And so it shall be. It is a pine cone. So the pineal gland is large in children, similar to the thymus. But after about the age of 7, it begins to go involution style like the thymus does, where it starts to shrink. So the pinealocytes shrink and involute. A lot of them are converted to fat. And by the end of puberty, it's only about 75% of what it was. And it's pretty little in grown-ups. So it's thought to have a role in regulating the timing of puberty in humans, along with other timing functions, including leptin amount, body adiposity, the suprachiasmatic nucleus of the hypothalamus, which is right there, and a bunch of other things. So it does a lot of stuff, but I do want to stress that shrinkage of it is normal. Fun pineal gland facts. Fact number 1, you may recall René Descartes, the philosopher and mathematician who invented Cartesian coordinates. You may also recall in his philosophical pursuits, he dabbled in all kinds of epistemological thinking and developed like a proof that God exists and a bunch of other things. René Descartes decided that the pineal gland was the anatomical seat of the soul. So for a long time, science and religion, specifically Catholicism and Christianity, were actually pretty closely linked. So they weren't always as at odds as we think of them as being. And one of the reasons for that is like, who has more time to think deep thoughts than people like monks, right? Or very, very wealthy people like René Descartes. But regardless, there was less separation of those two things. And so a lot of people spent a lot of time and energy trying to figure out where in the human body the soul lived, which made sense to do at the time. And so René was like, well, this is the only thing that's not bilateral, and it's like really, really deep in there. So I think that this is the soul's house. And then people kind of just accepted that for a long time. So one of the things that the pineal gland does is during the daytime, it makes serotonin. And then during the nighttime, it makes melatonin. So if you divide the day up, as far as what the pineal gland is doing, the relative length of the serotonin pulse compared with the melatonin pulse encodes how long the daytime is. So you're going to have more melatonin secretion per day during the winter months and less melatonin secretion per day during the summer months. So the pineal gland, along with input from the suprachiasmatic nucleus and a specialized group of neurons called the retinohypothalamic tract, basically provide a chemical signal about day length and day time that your brain can use to make decisions about things that time matters for, like puberty, for example. It also unfortunately affects mood, as some of you may be familiar with. We live in a place where it's crappy and dark for a significant portion of the year, and a lot of people have a really hard time with that. Seasonal affective disorder is what that's called, and that is thought to be related to light exposure, and that can be somewhat ameliorated by getting exposed to light to reduce the melatonin levels released per day. Another way you can mess up your circadian rhythms in not a good way is if you look at your phone in bed with no orange light filter. Yep, exactly. Monica is exactly right. Yeah, so you're not supposed to look at your phone in bed because the wavelength produced by phones is blue and the sky is blue, and our retinohypothalamic tract neurons, which are not for seeing, they're for detecting blue light. And when they detect blue light, they're like, it must be daytime. I'd better go tell the pineal gland that it's daytime. And so you're staring into this little blue void, and your brain is like, wait, but I thought it was nighttime. What's happening? Let's never sleep. And I am also guilty of that. So the best advice I can give you is turn on the light frequency filter on your phone. And that does help. Or you can turn monochrome, but you can also get ones that like change the frequency peak to be more orange, and that helps. Simulated sunset helps our brains. Very well may be. Okay, so pineal histology, not a whole lot going on here because it's pretty much just one cell type, which is pinealocytes, creatively named, I know. So pinealocytes are obviously the cells of the pineal gland. Remember, they secrete serotonin in daytime, melatonin at nighttime. So, of course, there's venules, which allow the melatonin and serotonin to enter the bloodstream. There's also septa, which are just like any other septum. They're connective tissue. And there is a thing called the corpus arenaceum. Another fun name for this is brain sand. And it's basically minerals and protein aggregates that build up and crystallize in the pineal gland. It seems to be related to the biosynthetic pathways that produce melatonin and serotonin respectively. So over time, these things build up in the extracellular environment and seed a little crystal, and then you get a pineal concretion or brain sand, which is this and this. So interesting pseudoscience application. People that are very afraid of the whole water fluoridation thing will blame fluoride for these pineal concretions. And then you see all this mumbo jumbo on the internet about how having a crystallized or calcified pineal gland is a result of government intervention in the water and or evidence that you are a lower order being because your third eye is full of calcium crystals, blah, blah, blah. But the reality is it's a normal part of pineal aging. Also, you kind of want to have at least a few of these because God forbid you should ever need to get your brain irradiated. But these are radiologically shiny. And a lot of radiologists actually use the pineal gland and its concretions as an orienting illuminescent structure to make sure that they're looking at the right part of the brain, just due to the way it is. So pineal concretions, brain sand, not something to be afraid of. Not evidence that the government is controlling your thoughts, which always gives me a chuckle. but rather just a regular part of pineal aging, totally normal. Yeah, my one of my least favorite discussions to have is trying to explain to people with deeply held pineal beliefs that their emotional connection to their pineal gland is twee and wrong. To answer your question, I don't know if they would show up on an MRI or a CT scan for sure. I would assume so, however, because they are of a different density than the surrounding tissue. Okay, so here we have a little summary slide. As always, it's a useful resource or a quick look, but not something to, get all your information from. But it's really helpful as a shorthand, so keep it handy for tests. Okay, and now we are going to pivot over in the remaining time to the next subject matter. So I'm going to pause the recording here while I get my other PowerPoint pulled up, and then we'll resume. So now we are going to talk about reproduction, and I am almost as nerdy about this system as I am about the endocrine system. Unsurprisingly, they're related to each other and they're fascinating. I do want to take a moment to acknowledge that there is some antiquated terminology in this PowerPoint that I haven't had a chance to fix yet. So just I'll point it out when it comes up and say what it should say instead, but just heads up. We always try to be as precise, but also as inclusive and mentally flexible as possible in our biology department and in my classes. And it's never going to be my intention to be reductive here. So that's kind of the philosophy that we're going forward with, because biological essentialism is mistaken and fallacious reasoning, and it's not the practice of good scientists. So that is not what I want to do. And if you are watching this on my YouTube channel and you are not one of my students and you disagree with me, feel free to not comment about it because I will not respond to your comments. Alrighty, so I want to sort of contextualize this discussion by talking about some of the unique problems of the reproductive system. This, by the way, is an SEM of the seminiferous tubules. So the testes are a wadded up group of tubes, and inside of those tubes, sperm are born. And sperm are the only human cell with a flagellum, and also the only gamete that is capable of motility, which means swimming. So we're going to do male reproductive system first, female reproductive system second. And when I say those things, I mean primary gonad and, in most cases, but not all cases, gametic sex. There's some wiggle room there as well. But that's generally what I'm talking about. But both sets of gonads share the same challenge, which is produce via meiosis cells that are genetically distinct from the individual and package them in such a way that it's possible to combine them with another gamete to produce a new individual, but also protect the gametes from your own immune system. Because after you undergo the genetic deck shuffling and rearrangement of meiosis, the gametes that we all produce are no longer genetically identical to our somatic cells, and therefore those cells are at risk of being attacked by our immune system. So we're used to thinking about things like the blood-brain barrier, but you may be surprised to know that there is also, for example, a blood-testes barrier. So there's all kinds of sort of interesting and secret sort of niche facts that you may never have considered when considering gametogenesis and its challenges and just how complicated all this stuff is. So these are the classical definitions based on observations of both genitalia, internal and external, and gametic sex. So when we say male, what we typically mean as scientists is the sperm producing member of the species, which introduces gametes into the female. And then female reproductive system produces ova, which are also special, although not flagellated. They're in most vertebrates, for example, really large compared with somatic cells and have all kinds of other cool features. And this cell is going to selectively permit a single sperm to combine with it. And then the rest of the system is designed to provide a comfy place for an embryo to implant and hopefully give it time, space, nourishment, and room to mature and undergo parturition and delivery. So the primary sex organs are the gonads. These are testes or ovaries. So they're called primary because they actually produce the gametes in question. So secondary sex characteristics, like for example, a penis or a vulva, these are more involved in the act of reproduction. They don't actually make anything that is particularly useful for making a new person. So there's a system of ducts, glands in both. In the case of the male, we have a erectile tissue that we call the penis that delivers the sperm cells, and then a protective piece of skin called the scrotum that houses the testes. In the female side of things, we have uterine tubes and a uterus. And then externally, we have a vulva, which surrounds the vagina. And this basically receives sperm, and the uterus harbors a developing fetus, or doesn't, and menstruates to get rid of the layer it built up. All of these parts, though, come from the same set of parts, which is super interesting. So before either of us had either vulvas or scrotums, we had a labioscrotal fold. And before you had the ducts that you now have, you had either a Wolffian or a Mullerian duct. So we actually all start out with the same kind of starter kit, let's say, for how to be a sexual being. And then depending on what hormones are present during development, you kind of take one trajectory or another, or an intermediate choice. So I will acknowledge the existence of intersex people periodically throughout this presentation. And one of the reasons is intersex people are about as common as people with red hair. So if you're thinking to yourself, but I've never met an intersex person, you probably have. It probably just wasn't relevant for them to let you know that. So we have a species in a mating system in which the heterogametic sex, meaning different gametes, is considered male, and the homogametic sex is considered female. If you've taken comparative biology or vert-zo at all, or even embryology, you might be aware that that's not true for all vertebrates. So chickens' sex determination, for example, is ZZ or ZW, and there's all kinds of other combo possibilities. And for some organisms, you're male if you have two of the same gamete instead of two different ones. So this is just the human version of it. There's lots of different options elsewhere in the vertebrate world. So really all it comes down to is a presence or absence of a Y chromosome. And this is where the ideology of biological essentialism kind of comes from, is this like critical presence or absence. And that's boils down to just how evolution happened to have this work out for us. So you either have a Y chromosome or you don't. Most of the time, if you have two X chromosomes, you don't have a Y, although we will talk about Klinefelter syndrome and other polyploidies where you have more than two sex chromosomes, which is cool. And yeah, absolutely. So we will talk about hormone replacement therapy and gender affirming hormonal therapies. They actually do change the external genitalia, which is neat. So this presence or absence of a Y chromosome we'll discuss, but the Cliff's Notes version is there's a specific gene. So in addition to this determining sex, there's also sensitivity to sex hormones. So androgen insensitivity syndrome is a situation where there is a heterogametic individual, and the testes are producing normal testosterone levels from the Leydig cells. But for whatever reason, usually it's a genetic mutation, androgen receptors are either not present or they don't respond appropriately. So in these cases, female development is the quote unquote default setting. So even though there are testes present, the external genitalia develop as female. Usually, no one notices this until the time for puberty and first menstruation menarche comes and goes, and everybody's like, so, and then it gets checked out. So it's often not even noticed until later in development. Okay, so I mentioned that everybody starts out with kind of the same bits. Here's what I mean. This is really cool. There's also a Radiolab spin-off show called Gonads, I believe, that does a really good job explaining the developmental happenings that take you both to this point and away from it towards one trajectory or another. And it turns out that there is actually some gene expression that makes sure that you keep having ovaries or keep having uterus or keep having testes, even once puberty and sex differentiation is over. One of them is called DMRT1, for example. So we have 22 pairs of autosomes, meaning the cells of us that are not sex chromosomes, and then we have one sex chromosomes. So on the Y chromosome, there is a gene called SRY, which stands for sex determining region of the Y chromosome. And that codes for testes determining factor, which does exactly what it sounds like it does. It determines that the gonads will become the testes. So before that, you have a cloaca, just like a turtle or a chicken. And then there's this sort of widened area. And then you have some kidneys. So these are going to develop into your urinary tract. That's why the urogenital assortment of organs is called urogenital, because they're developmentally related. And then you have both a Mullerian and Wolffian or mesonephric duct, and then which one of these you keep and which you discard ends up determining your ductal system. So there's a question in the chat, and that is it possible for the SRY gene to fuse to an X chromosome? That's a great question. I have no idea. Because yeah, absolutely, as you're acknowledging, there's in the Robertsonian translocation, there is a possibility for like bits of chromosomes to stick to each other, especially if something goes weird during crossing over where stuff fails to disaggregate. But as to whether that specific gene has ever like ended up on an X chromosome and been expressed, I have no idea. It's a great question. What I suspect is that if it were present, you would not notice phenotypically because male development would be presumptive after that. But like I said, I'm not sure. I would recommend looking it up. I'm going to. It's a fascinating question. Okay, so let's look at what happens as things proceed. So if we've got a sex determining region of the Y chromosome present and active, you have the mesonephros. If we look, well, mesonephros is this orange bit right here. So keeping track, the mesonephros is going to begin differentiating into the testes. And then we have the mesonephric duct develops and the paramesonephric duct degenerates. As you can see, that top vesicle of the cloaca becomes the urinary bladder. And then we get development of the glandular system as well. So the seminal vesicle begins to develop. The prostate gland develops at the base of the soon-to-be bladder, etc. Another thing that needs to happen is that as the testes develop, they have to descend. If they fail to descend, sometimes they get stuck to the body wall, for example. That is called cryptorchidism, which means hidden testis. And if I'll spell that for you here. And if you're wondering what that has to do with orchids, the word orchid, which we refer to as the flower, means testicle. So someone saw an orchid flower at some point and was like, wow, that sure looks like a testicle to me. And so it shall be. So if you've ever wondered why orchids are called orchids, that's why. The more you know. So the testes also secrete, in addition to testis determining factor, a Mullerian inhibiting factor, and that's what causes the paramesonephric ductules to degenerate. If there is no sex determining reason, we get the differentiation of the mesonephros into ovaries, and the paramesonephric duct is the default. The joining of it here is what becomes the uterus, and then the cloaca actually separates. In this case, it's moved aside so you can see, because of course, in the anterior view, in the pelvic cavity, the bladder actually has the uterus tipped over onto it. So if estrogen was the hormone that directed female development, as is the presumption based on how the hormones work in adults, all fetuses would be feminized because, of course, if you think about it, right, estrogen levels are high in pregnancy. We've got the placenta, and before that, the structures of the ovary producing progesterones and estrogens in super high amounts. So speaking of this and of other organisms, just to do a little bit of comparative anatomy here, you can see how there's two mirrored sides to what will eventually become the uterine tube and the uterus. Just like with spina bifida and other midline defects, it is possible for stuff to go a little bit sideways during female internal development, which results in a wide assortment of different sort of options, let's say, for how the uterus looks. So let's look at a couple of those. So these are of gynecological interest because they are reflective of wherever the uterus paused during development. But they obviously, as you can see, can have some pretty severe consequences for someone with a uterus's ability to carry a child, right? But it's not hard to imagine how something like bicornate uterus or uterus didelphys would result when you can see how the development proceeds. And then in extreme cases, you actually can have, as you can see here from uterus didelphys, two vaginas as well. So yes, it is theoretically possible, as you are acknowledging in the chat, to actually have two functional uteruses and carry two pregnancies at once. It's very unlikely, but it's not impossible. Final note on the feminizing effect of estrogens. Other creatures like, well, I just showed you a litter of puppies like dogs, or in a livestock situation, a lot of other vertebrates have a sort of boomerang or U-shaped uterus, especially animals for which multiparity is the norm, so having lots and lots of babies inside you at once. And you can look this up. I recommend it. It's interesting. Male offspring that are between two females in that uterus arrangement tend to have more feminine attributes and behaviors, and female babies that are between two brothers have the converse true. And it's because steroid hormones are fat soluble and they have no problem getting through cell membranes. So during development in litter carrying animals, in addition to the hormones of pregnancy, hormones are leaching from sibling to sibling and influencing the development of their neighbors as it proceeds. So that's a fascinating outcome of multiparity. we don't normally deal with that because humans aren't really supposed to carry multiple fetuses at the same time, which is why twin pregnancies and higher are considered to be high risk. But yeah, it definitely does affect the outcome of the pregnancy, depending on, you know, what hormones are kind of sloshing around in there. As far as leading to androgynous twins, I haven't the foggiest idea. Reasonable assumption, not sure. And then that's an interesting observation. I didn't know that about the cows. If there's FM twins, the F is usually infertile, but it doesn't surprise me, especially if you look at the size of the testes in male cattle, due in part to artificial selection. It extra doesn't surprise me. Okay, so let's look at the external genitalia, and then we'll pick up where we left off next week. But this is also fascinating. So I just showed you the homology of the internal set of workings and that they all come from the same thing. The external genitalia follow the same rules. So before either of us had a clitoris or a vulva or a penis and a scrotum, all of us had a fun thing called a genital tubercle. And this is just basically a protoglans. So this is the thing that becomes heavily innervated and is involved in the enjoyable sensations of sexual intercourse. We also had a urogenital fold and a labioscrotal fold, which differentiate as follows. The phallus is interesting because it basically starts out open and then closes inferiorly, which creates the phenomenon of having a single inferior erectile tissue, the corpus spongiosum, and then two ones on top. And then things stay a little bit more open over here. So we have the labia minora and the urethral groove, which eventually accommodates the urethral and vaginal orifices. And then the urogenital fold becomes the labia minora and the labioscrotal fold becomes the labia majora. Whereas things sort of tubularize and close up over here, the urethral groove closes and the urogenital fold becomes the penile and perineal raphe, which is this kind of closed up seam. And then the labioscrotal fold encloses the testes and forms the skin of the penis and the prepuce or foreskin as well. So if you think hard about the quote unquote feminizing or quote unquote masculinizing hormones that are at play during development and that drive this differentiation as a result of the presence or absence of testis determining factor, it is absolutely possible, and I would even say quite a bit more common than you might think, for there to be intermediates between each of these finished products because they are so mutable and because ultimately, at the end of the day, we all started out with the same stuff. So both internal reproductive and external reproductive development are fascinating. And I do want to stress that this is sort of the textbook binary developmental trajectory based on an average of development and is by no means the be all and end all of how things end up looking. Alrighty, and it is time to stop for today. So when we pick up next week, we will resume talking about the differentiation between these things and what that looks like under a microscope.